Welcome back to the program. You are watching the PM edition of Newsfeed here on Newsroom Africa channel 405. My name is Oliver Dixon. In this half hour, we'll be in conversation with the Deputy Public Protector, Advocate Kholeka Gcaleka. And she and with the Public Protector released a very damning report into the state of hospitals and healthcare facilities in South Africa. And hospitals continue to be under siege as a result of COVID-19 second wave, and the Public Protector's report released described at least the state these hospitals and healthcare facilities find themselves in, many of them not having adequate PPE, many of them being short-staffed, and many of them not functioning at optimal capacity. 17 hospitals were inspected by the Public Protector's report that has been documented, and we'll take a look at the details pertaining to that. And joining me to have this conversation is the Deputy Public Protector, Advocate Gcaleka. Advocate Gcaleka, thank you so much for your time. Really appreciate it. Welcome to the PM edition of Newsfeed.
Good afternoon, Oliver, and good afternoon to your viewers. Thank you for having me on your show.
Now, there are multiple issues that you guys address in this report, and I do want us to look at it over the next 30 minutes or so. But what I want to start with are sort of just the bottom line issues. And one of the issues that is documented in this report that you guys have drafted is a concern about bureaucratic red tape, which, for instance, doesn't allow certain CEOs of hospitals the same functions it allows other CEOs of hospitals, and the processes they go through to procuring maintenance resources, for instance, or even just PPE sometimes is the discrepancy therein is a bureaucratic nightmare. Let's take a look, for instance, at the CEO of George Mukhari Academic Hospital, who is only permitted to procure up to 500,000 for instance. But down the road at Sefako Makgatlo Hospital, the CEO there is allowed to procure up till 5 million. Is this a new phenomenon, or is this a long-standing problem in the healthcare value chain?
It is not a new phenomenon. It has been reported to us that it has been there for momentum in time, and the CEOs has tried to raise the discrepancy and the challenges that this red tape is bringing upon them. However, this is a delegation that is decided by the province, and in large areas it is kept by the province, and the CEOs are only allowed to procure as per the requirement of the province.
What's the reason, at least, why provincial governments, where it is saying the same province would prescribe different powers to different CEOs in hospitals in the same province? Is there a specific reason why that is the case, or has it been an arbitrary process for the most part?
It's been an arbitrary process, really, but it is really impacted by the classification of the hospitals, depending on whether it's a district, a regional, or a tertiary hospital.
When it comes to staffing, which is also an issue that is addressed in this report, what's the reason for understaffing? Is it in large part due to the bureaucratic red tape, or is it a budgetary issue?
That too is largely because of the bureaucratic red tape. Most of the positions, senior positions, particularly positions of the clinical staff, those vacancies are filled by the province. Therefore, the process that takes place from the hospital itself, writing up a submission to the province on the vacancy, the province advertising, and taking into consideration that the province has its own priorities as a provincial office, and they have several hospitals that are under their mandate. Therefore, it would not be as quick to fill those posts and undergo the recruitment process as it would be if the hospital would do that on their own. Therefore, that too is due to the red tapes, and also because of some of the moratoriums that the province has put in place that have a long-term effect on the vacancy rate of the hospitals.
Another issue that falls victim to some of the bureaucracy is the procurement of PPE, which in large part has been centralized to the provinces and not the hospitals itself. And your report frames that as a problem, an issue that needs to be addressed. Why should it be the case that hospitals should have autonomy on PPE procurement away from provinces, and that provinces should not be centralizing that competency?
We have seen the challenges that has brought about. I mean, across the board in all the hospitals and in all the provinces that we have gone to, what has been the major problem has been the issue of accessing those PPEs once they have been procured by the province. It takes long for the province to procure the PPEs because it procures for the entire province. The delivery those PPEs, for example, in Charlotte Maxeke, they indicated that they had to use their laundry van to collect the PPEs from where they were stationed. Now, that also gives another challenge. Then it means that during that particular period, they are unable to transport the laundry to where it is supposed to go. But also because of the challenges that have been faced of the quality of the PPEs, the sizes of the PPEs, the specific requirements, they are not universal to all the hospitals. Some require more masks, some require more gloves or body cover more than any other. So the province would have a blanket approach in respect of the procurement of those PPEs, which have seen major challenges within these hospitals, also resulting in a shortage of PPEs or resulting in no PPEs at all in some of the hospitals.
Am I understanding this correct? A provincial government would say that Hospital A will receive 1,000 units of PPE, and Hospital B will receive 1,000 units of PPE. Meanwhile, Hospital A has a bed capacity or at least a staff complement of 800 people, while the other hospital only has a staff complement of 200 people. Is that hypothetical scenario a correct representation of what you just described?
Unfortunately, yes. And hospitals would have submitted their specifications, including the numbers that they require, but when the delivery takes place, that would not be the case.
Let's talk about the substandard PPE that you just mentioned. In the report, you mentioned that a number of suppliers either didn't deliver or delivered substandard. Now we know that there are ongoing investigations by a unit put together by President Ramaphosa. The Hawks, as well as the Special Investigations Unit, are looking into some of those suppliers. But have you been able, because you do not name it in the report, but have you been able to identify some of the culprits in that instance?
That is a separate investigation for us, which we are still undergoing. This is purely a systemic investigation that we have undergone on the state of the hospitals, which does not necessarily deal with the discrepancies and the procurement irregularities that have taken place in result of the PPEs.
Talk to us about the status of that ongoing investigations. How far into that are you guys? And when can we expect perhaps any sort of preliminary feedback on the investigation into the suppliers?
We are at an advanced stage, and as you know, in respect of investigations, we are unable to give preliminary feedback because we have to observe the audi alteram partem rule. Therefore, it will only be once the public protector has signed off the final report that, as per the requirements of our rules, we would then have to make the report public. We are really hoping that by the end of this financial year, we would be able to release that report, unless there are some consequences that prevail that would prevent us from releasing those reports.
Before we look at your interventions, because you have short and medium-term interventions, and I'd like us to look at some of those, let's take a look at consequence management and accountability where some form of maladministration takes place. Now, one example that I picked up in the report was that Lillian Ngoyi Clinic, for instance, there's a doctor who went on lunch for 3 hours, and you found this out when you were interviewing some of the patients who were there. This doctor went on lunch for 3 hours. Some of the doctors there don't even sign the register, and when they get fired, they just get rehired through processes that aren't even supposed to have been followed. Are you worried about that? And to that effect, what is the remedy for that?
We are indeed worried about that, and the remedy is very clear. Government has to follow the Labour Relations Act in respect of consequence management and monitor the exits within the departments and find out what would be the reasons for the exits and be able to track and trace who exited, how and when, and that is unfortunately not the case currently, and that is what has been reported to us. Hence, most of the doctors are being rehired into the hospitals where they had left because of ill discipline.
And the unions, which you characterize as miscommunication existing between the unions as well as the departments, as well as the hospitals, what's their role in assisting the departments and the value chain with delinquent staff who do not sign registers, who go on lunch for 3 hours and that sort of thing?
Unfortunately, that didn't become part of the discussion because the focal point really was on the state of the hospitals. But in our view, the role that the union is supposed to play really is to assist in ensuring a stable institution in all form, meaning that even in instances where their own members are not adhering to the requirements of their employment, the union should be able to assist management in that regard.
On the other side of this, I want you and I to look at your interventions proposed in the report, the short-term as well as the medium-term interventions, how we expect that to play out, what the timelines are associated to that, and what responses the Office of the Public Protector has received since issuing this report from the relevant authorities. We'll have that conversation on the other side of this. Let's just take a quick break. Welcome back to the program. We continue our discussion with the Deputy Public Protector Advocate Kholeka Gcaleka, and this discussion is about the reports that the Public Protector's Office had published about the state of our healthcare facilities across the country. They had inspected 17 healthcare facilities and released an incredibly damning report about the state of those facilities. Advocate Gcaleka, thank you so much for being a part of this conversation. Let's take a look at some of your intervention. Now, you have two categories of interventions that are proposed in the report. One are short-term interventions and the other long-term interventions. When it comes to the short-term interventions, you speak about how the departments need to ensure that hospitals have their own testing capabilities. That's to say that they should have enough COVID-19 tests to lower the turnaround time. What response have you received from hospitals and from provincial departments with regards to the implementation of that suggestion, or at least remedial action in the short-term intervention?
Let me just explain this, Oliver. This is an intervention report, which we have discussed with the Minister of Health in September, that pending the finalization of our final report, which will have remedial actions, we wish to bring about an intervention report because these are not ordinary circumstances. It's not an ordinary matter that we're investigating. It needs speedy intervention. Subsequent to that, we then released this intervention report in December, and we had agreed with the Minister of Health that we are going to have a meeting early this year, and we are hoping that we are going to have it during this month of January, where we will meet with the Minister of Health and the MECs of health throughout the country who are affected by this report to then put in place a proper plan and in respect of their budgetary requirements and capacity, what is possible and not possible. However, this is our proposal in terms of our intervention report. Our remedial action report, where we find a wrongdoing at the end of our formal investigation, will be released in due course.
So this report is not punitive, neither is it adversarial. You're suggesting to them what could be done in the interim to fix the problem given the urgency of the matter. So again, then I'll ask, has there been at least cooperative, a cooperative attitude from the various entities and stakeholders in making sure that these interventions are taken serious in the short term? And that is to say, do you know if hospitals and departments are now taking serious, for instance, ramping up testing capabilities of healthcare facilities?
At this stage, we haven't received any communication in that regard. As I say, we released this report towards the end of last month. However, when we had met with the Minister of Health and we had indicated all these proposals to him, he was quite receptive of them. And it also indicated that from his office as well, he does have a team that has also looked into these issues. And the proposals that we are actually bringing up are similar to those that he will also be implementing. Therefore, the Department of Health is quite receptive to this report.
In your medium-term interventions, you speak about increasing the number of ambulances. Now, you don't speak about figures in the report, but how many ambulances are enough? That's to say, is there perhaps a ratio that you think is suitable that describes, for instance, how many ambulances per how many thousands of citizens should be in each province or each region? Have you perhaps thought about that?
We are really leaving that up to the Department of Health, but of course, at least a particular radius or ward must be covered in terms of ambulances, and not just have ambulances that go all over the place. Also, to attend to the issue of time at which the ambulances would reach the patients.
And also in the medium-term interventions, you ask that departments ensure that they have business continuity management plans in place, as well as risk strategy management plans in place. What are those and why are they important?
Those are very important. I'm going to start with the risk management strategy and plan in place. That really, not only for the hospitals, but for any other institution, it assists the institution to assess its environment internally and externally, and any other factors that impact on its business, and be able to plan ahead and be able to close the gaps of those particular risks or threats that they would be facing. And in respect of the business continuity, particularly with the hospitals now, not having that strategy, it should at least cater for disasters in general. Now, most of them do not have them, and the few that has them, they do not cater for disaster management. Therefore, hence we are faced with the challenge that we are faced with as the country, where certain operations have been postponed indefinitely because there is no plan that we need to put in place that should this disaster take a particular period, this is a particular plan that we are taking in place. So those two strategies and plans are really important to ensure that there is no crisis deriving from a particular disaster, no matter what the disaster is. And particularly in this instance, the pandemic that we are facing as a country. But as well, it also helps to mitigate a lot of risk factors, such as what we had been reported to from some of the hospitals, is that some of the infections have derived because of the risks that are there within the hospitals. These were subsequently not properly assessed nor analyzed, therefore they could not mitigate those particular risks. So really, for any institution, and particularly the healthcare facilities in this instance, it does assist to mitigate factors that contribute adversely to the business.
And is that also why the business continuity management plan is in place? Because to that effect, in the report, you speak about this plan being in place specifically for things like elective surgery and how that will be phased back in. Why was that an issue that came up?
It is an issue that came up because in most of the hospitals, you found that there are a lot of patients who are awaiting to do elective surgeries, and no concise communication could be given to them on when the hospitals would be able to implement this and how the hospitals would be able to implement this. And some of these surgeries might be elective today, but in a short or longer term, they might become a serious challenge for the patient, they become compulsory to do. So those are the things that the hospitals have to look at, which they have not been looking at.
Now let's talk about the nature of this report. At least in my memory, the Public Protector's Office puts out reports that have very strict remedial actions which are binding and sorts of stuff. This is not that kind of report, but yet you embarked on it across the country, 17 hospitals. Would you have liked to have done more hospitals, and what was the concern there? Was it an issue of you guys not having enough money in the Public Protector's Office, or was it not? Did you guys not have enough time to be able to do that?
Your question is two-phased. I'll address the first part of the question on the type of the report that we've issued. If you recall, I said earlier on in the interview, this is an intervention report that we have decided to compile whilst we are busy with our formal investigation into our ordinary, what I would call our ordinary report. So this is not the last time that you hear of us releasing a report into the state of the healthcare facilities into the country. This is an intervention report to ensure that the Department of Health is able to urgently look into these matters and plan ahead whilst we are finalizing our report. So we are going to issue a report in the ordinary course of our investigation, as we do in any other of our investigation. But because of the nature and the state of the healthcare facilities and the reports thereon and some of the complaints that have come before us, we have decided that it is rather in the best interest of the country, the citizenry, that we have this unusual report, which we call an intervention factual report. Now, we would have loved to go to each and every province in the country. Unfortunately, we are also not in a good state financially. We therefore have had to prioritize the provinces where there were the most complaints and most challenges. However, this really shows the state of the hospitals in the country, because having gone to 17 hospitals, 5 provinces across the country with different dynamics from urban to rural hospitals, it really shows what the state is within our country.
And I mean, usually when a large-scale investigation takes place, the Public Protector's Office has, traditionally not been well funded. And so what they would do is, and we've seen this, for instance, if we look at the State of Capture report, the then Public Protector said, hey, maybe set up a commission solely dedicated to this. Investigating hospitals, I don't assume, is a small investigation either. You're investigating multiple institutions. Usually that would have been, at its scale, something that a commission of inquiry of some sort would need to look at. But you guys are still keeping this investigation internal. And so I'm really worried about how much this costs and whether the Public Protector's Office has enough money, given that that has been a complaint of time and time again. And has the office perhaps spoken to Parliament and the necessary portfolio committees about budgetary concerns regarding this particular investigation?
We have spoken to Parliament really concerning our budgetary requirements on overall on our investigations regarding COVID, which also involves this. Unfortunately, there is no money in the country. We had to make do with what we have. And fortunately for us, there are other institutions. The Department of Health itself has conducted some form of an investigation into the state of its hospitals, the health standards, the health ombud. So there is really consensus, because we have met with these institutions in respect of what we have observed and in respect of what we are recommending, because even before releasing this report, we have had wide discussions with those particular institutions. So we are definitely on the right track. The issue of a lack of funding is really not affecting this type of investigations that we are embarking on.
Advocate Kholeka Gcaleka, thank you so much for your time. I really do appreciate it. And I look forward to the remedial action, or at least the ordinary report into the state of hospitals in South Africa, where more binding action will be taken against hospitals and officials who are delinquent and otherwise flouting regulations and, costing the state a lot of money and present an opportunity risk. I really do appreciate your time. All the best to you, your team, and the Office of the Public Protector for 2021.
Thank you, Oliver. All of the best to you and all of the best to your viewers.